So let's talk pathology of the GIT. Now the GIT, the gastrointestinal tract, is one long tube from your mouth all the way to your anus. And we'll approach it systematically. We'll start by talking about pathology of the mouth, and then the esophagus, stomach, intestine, and then finally the anus. So we'll start with the mouth, and just general observation of a patient can tell you a lot of things when it comes to GIT pathology. So for example, the first topic is going to be cleft, lip, and palate. That's something you can pick up right off the bat. It's quite incredible how we develop in our, especially in our head areas, basically two sides fuse together. And the lip and the palate is no different. You basically fuse together these prominences. And if they don't fuse correctly, then you can have these defects, and so you have a cleft lip. The picture will be on there in my notes. You can also have a cleft palate, so the palate doesn't fuse together. You have a little hole, essentially. And the cause is multifactorial. Genetics plays a role, drugs play a role, maternal care plays a role. So all these things play a role, so I'll just write multifactorial. And it's not just a aesthetic problem. It can actually cause things like feeding problems. You can imagine if you have a cleft lip or a palate, you can't feed as well or breastfeed as well. So feeding problems. And then also your eustachian tube doesn't form correctly, so you can have chronic otitis media. Chronic otitis media. So that is cleft, lip, and palate. Let's say a patient's a little bit older, comes in complaining of a sore in the mouth. And you look in the mouth, you see this gray erythematous sore, so it's a gray ulcer. This is very characteristic of an aphthous ulcer. This grayish ulcer can be painful. These ulcers can come from stress, and they kind of regress, and they kind of come and go depending on the stress level of the patient, but also can stem from autoimmune and GIT disorders. Something about autoimmune disorders, they really like to affect the mucosal surfaces. Speaking of which, you can have things like Behçet's. This is an autoimmune small vessel vasculitis. Vasculitis. And here you can have immune complexes, and those can deposit and cause ulcers. You can have ulcers in your mouth, aphthous ulcers. You can also have ulcers in your genitals. You can also have deposits in your eyes and uveitis. So I write ulcers, uveitis. So look out for that. Another patient comes in. Again, all general observations still at this point. Complains of a sore now on the lip. You see this red vesicular sore. What are you thinking? You're thinking of oral herpes. HSV1 is the causative agent. If you remember, you have HSV1 and HSV2. Traditionally, they've been known to cause different things, but that distinction has kind of been melded away. So for your intents and purposes, HSV1 causes oral herpes, and these are these really painful red vesicular lesions. Again, the picture will be in my notes. HSV1 is a common infection in our day-to-day language. We just commonly call it a cold sore. A lot of us are infected, have been infected with HSV1. It infects your mucous epithelium, and then it lies dormant in your trigeminal ganglion. And for the most part, the majority of us, it never resurfaces. But sometimes you can have stress, or even sunlight can cause it to resurface. And when it resurfaces, causes that cold sore, that oral herpes. That's HSV1. Let's talk about cancers of mouth. Cancers of mouth. Now, oftentimes you don't just go from 0 to cancer. There's some kind of progression. And if you have chronic inflammation, then you can cause cells to progress, cause dysplasia, and then ultimately cancer. Some forms of this chronic inflammation is things like smoking. Smoking is never good. Not only does it cause chronic inflammation, but it's a carcinogen by itself. Alcohol, same thing. And so those are big risk factors. And that dysplasia you initially see is going to be kind of a compensation for that chronic inflammation. Will be a reaction to that inflammation, and will show up as a white plaque or leuko, white plaquia, white plaque. Now there are a lot of other white plaques that you can see in your mouth. You can see Candida, that's a fungal infection. Or you can see an EBV infection called hairy leukoplakia. How do you tell the two apart? Take a little tongue depressor and you try and scrape it off. If it scrapes off, then it is Candida and EBV. If it doesn't scrape off, then it's leukoplakia proper. That is dysplasia. You can also have more severe dysplasia, and it actually causes blood vessels, these kind of abnormal blood vessels. That's not good. That's even worse than normal leukoplakia. We call that erythroplakia, and that is even higher risk of cancer. All those blood vessels will make the white plaque turn red. You get the red plaque. That's the erythroplakia in the name. And again, that's high risk of cancer because of those abnormal blood vessels. And then eventually that dysplasia will progress and then cause squamous cell carcinoma of the mouth, SCC of the mouth. I think that's all I want to talk about of the mouth. Let's move on to something still in the oral cavity. We're still in the oral cavity, but let's talk about salivary glands. Those are those glands that help you secrete digestive enzymes, the main one being your parietas, but don't forget about the other ones. Sometimes you can have infections of your salivary glands. A big one is going to be the mumps virus. Been more or less eradicated because of vaccines, but if a patient hasn't been vaccinated or is an immigrant, you might be suspecting this, especially if they have enlarged parietas. So bilateral enlarged parietas. A complication that you must know is that in teenagers that have mumps, it seems to like to affect the testicles and can cause orchitis. Because it affects the testicles, these patients are at increased risk of infertility. Very important that you know that. You have another infection from Staph aureus. This general infection is just called sialadenitis. The itis part is the inflammation. So this is commonly from Staph aureus. Usually from you can have a salivary gland stone, cause a little blockage. All that bacteria starts to build up and cause inflammation, infection, Staph aureus. You have xerostomia. Xerostomia is not a disorder, as a symptom. That's just dry mouth. You're not producing as much secretions as you normally should. What can cause this dry mouth? Well, drugs can cause it. Can you recall what drugs cause dry mouth? Antihistamines can do it. Anticholinergics stops that sludge BBB, or basically the rest and digest part. You can also have something called Sjogren's syndrome. This is an autoimmune destruction of fluid-producing glands. So your eyes can produce fluid. That's what keeps your eyes lubricated. Your mouth, your salivary glands. So patients often complain of dry mouth, and eyes. Common question, they'll talk about how they find it difficult to eat foods or swallow foods because it's just so dry, it just gets stuck in their throat. Or they might say they always feel like they have sand in their eyes. They always feel like they have sand in their eyes because they're not making lubrication, so sand actually builds up in their eyes. So look for that. That's a common way of saying Sjogren's without saying it. Just a way to trick you. Next up on the list will be cancers of the salivary gland. First one is pleomorphic adenoma. What's in the name? Adenoma means it's benign, that's why I call it adenoma. Pleomorphic, basically made up of mixed material. This is a benign tumor made up of stroma, so connective tissue, and epithelium. That's the mixed part. And the fact that it's benign is the adenoma part. And it appears as this really painless, mobile mass at the angle of your jaw. So it's just a very painless mass. You can leave it or you can excise it. However, it has a high recurrence rate. If you don't excise it completely, it'll just reoccur. So just write may reoccur. Here's something you must know: for any benign tumor, it can turn malignant, and when it turns malignant, they can have facial pain. Why do they have facial pain? Doesn't cranial nerve 7 course through the parotid gland? So if it affects the parotid glands and it becomes malignant and starts to invade, it can affect that nerve and cause facial pain. So they'll talk about a patient who had a painless mass for a very long time, just this chronic benign mass, and then all of a sudden it grows or it starts to cause facial pain. What are you expecting? What happened is it was a benign mass and now it has turned malignant. So facial pain is a big red flag for it turning malignant. That's our first salivary gland tumor. Let's talk about our second one. This is Warfarin tumor. I don't really like this name. I prefer the technical name. Papillary cyst adenoma lymphomasticum. If you haven't figured it out by now, I really like figuring out why they call it what they call it. It usually gives away what the disorder is. So this is a cystic benign tumor. That's the cyst adenoma part that has a lot of lymphoid cells. And it's exactly what it is. So it's a cystic tumor that has germinal centers. Wow, that's the thing that B cells reside in. So you see all these lymphoid cells. Lymphocytes. Makes things very easy. If you just learn Warfarin tumor, you have no idea. You have no idea where to piece things together, but if you know the scientific name, then you can just figure it out. So if a question ever had a tumor in the salivary gland, you biopsied it and it showed a cystic tumor with germinal centers, and then on your answer choices had something called papillary cyst adenoma lymphomasticum, then what could it be, right? So that's why I just like learning the names. Last but not least, we talked about 2 benign tumors. Let's talk about a malignant one. This is called your mucoepidermoid carcinoma. Carcinoma means it's malignant. Because it's malignant, it can cause that cranial nerve 7 pain. So right, CN7 pain. What do you think this cancer is made out of? It's going to have a mucus component and a epidermal component. So the mucus component is just be mucus. Epidermoid part is going to be your squamous cells. That's it. That does it for the oral cavity, salivary glands. Hope you enjoyed the video. Thanks.